welcome and thank you for joining us this afternoon for today's session on steps to a successful Chargemaster review. So let's first start with some brief introductions. My name is Brad Josephson. I'm the Director of Marketing here at PMMC. And for those of you who are not familiar with PMMC, we are a leading provider of revenue cycle software and services with about 400 hospital clients across the country. Also joining me today is Kaye, Senior Vice President at PMMC. Greg's got 30 years of experience in healthcare and has been with PMMC for 20 years. Welcome, Greg, and thanks for joining us today.
Thanks, Brad.
Also joining us today is Tara Bogart. Tara is the Vice President of Revenue Strategy at PMMC. And Tara has 18 years of experience working with hospitals on issues related to today's topic of Chargemaster rate setting and price transparency. Tara, thanks for joining us today.
Thanks for having me, Brad.
So just a brief agenda. Today we are going to walk through some of the key factors that you need to consider when completing your next Chargemaster review. So really our goal today is to provide you with some tangible concepts that you can take back to your organization. One of the big themes that you'll be hearing throughout today's session is the concept of how to balance new price transparency requirements while still maintaining your net revenue objectives. I also want to challenge our attendees today to think a little bit differently about how we approach our Chargemaster and our annual Chargemaster review. We really always need to be considering a different perspective and always be willing to think forward. So on that concept of different perspectives and seeing things differently, we're going to pull the audience today a couple different times with some optical illusions. And what optical illusions are really doing, they're really caused when the wires in our brains get crossed. So our brains are processing millions of bits of information a second from what our eyes see to interpret what we're seeing. But not all of that information gets processed correctly. So sometimes there's just too much data to process, and we make quick decisions to prioritize the things we think are most important and only show those things to us. So what I'm going to do is I'm going to pull the audience really quick here and ask you, what do you see first when you first saw this image? Did you see a crocodile or a boat? So tell me what you saw, and then I'm going to tell you a little bit about what it means. So when you first saw this image, what was the first thing you saw? Did you see the crocodile or did you see the boat? And we'll give everybody a few seconds to respond here. All right, great. It looks like most of the audience has voted and the results are in. So let's share these real quick. So 88% saw the crocodile first and 12% saw the boat first. So if you saw the crocodile, that means you're most likely someone who tends to look at the bigger picture of things. And if you saw the boat, it means you've got a good eye for small details and not much gets past you without noticing it. So I'm going to turn it over to Tara, and she's going to kick off with the bigger picture on annual price changes, and then we'll get a little bit more into the detail.
Okay, great. Thanks, Brad. The exercise of changing Chargemaster prices has often been referred to as strategic pricing or charge optimization. Historically, hospitals would raise prices to maximize reimbursement within their contract limits, and services with percentage charge reimbursement were targeted to optimize revenue. So strategic pricing, it really is the cause for many hospitals having some services overpriced and others underpriced. And as part of the strategic pricing process, which maximized reimbursement, hospitals brought in data to use as guardrails. That way they could prevent standing out. But this process doesn't leave hospitals with pricing that is rational to the customer or pricing that's competitive with areas like surgery centers, imaging, retail clinics, things like that. So today, for many organizations, there are only a small number of payer contracts that have a percent of charge component, and the incentive to raise prices in these areas isn't as substantial as it once was. So we need to change the way we approach pricing. Hospitals need to rebalance pricing with the underlying value and begin to move our commercial payment terms in that direction without losing our margin in the process. And until the payers are willing to help hospitals realign pricing, hospitals will still need to pay attention to the market data, charge sensitivity, lesser terms, things like that. But there really needs to be a strategy to move toward rational pricing. The price transparency mandate is going to create some real challenges, one of which is how to implement this year's strategic pricing changes. CMS has indicated this process should take about 100 hours, but there are numerous things that have to be considered. Not only that, there's a layering process that occurs with each one. This complexity ties directly to the question that today's session is centered around. What are the key components to a successful Chargemaster rate adjustment this year? So it's important to start with knowing where you are in the market. Historically, it didn't pay for you to be below the market charge. Low prices often equated to missed revenue opportunities. Today, this is changing. With more price shopping and less charge sensitivity in contracts, lower prices can be an advantage. But every hospital is different. Your ideal price position will depend on the level of competition in your area and also the terms of your commercial contracts. So I'll share an example of a hospital trying to balance market position with a significant number of percent of charge contracts. A few years ago, PMMC was asked to perform a pricing project for a hospital that was 20% above all the local and regional competition. And I don't mean just for a few services. They were consistently really high. They knew it was from years and years of 10% price increases to boost the bottom line. And the organization was financially really healthy, but leadership said it was time to stop riding the gravy train. So the organization was still holding on to a few large charge-sensitive contracts, and they knew it was going to be a challenge when they decreased prices, but they wanted to get in front of the problem before they started losing market share. So PMMC modeled a lot of scenarios, and we worked to try and minimize the net revenue impact of the gross revenue decrease. But as you would expect with a 20% price decrease, the hospital still took a hit. Another example is a hospital that had mostly prospective payment commercial contracts. They were priced high in the market, and the board tasked the organization to lower charges because they felt that they could achieve a better market position without giving up net revenue due to the prospective contract terms. So PMMC modeled scenarios and provided analytics to show how net revenue trended alongside gross revenue decreases. We were also able to provide drill-down analytics to provide some insight as to why a hospital with flat rates on all their large contracts couldn't successfully bring charges down without taking a hit. And in this case, it was a Blue Cross traditional plan that was percent of charges, and it was lower volume, but it proved significant enough to impact the financials. Those two examples were challenging because both organizations were seeking significant price decreases, but for most health systems or hospitals we work with, we've been able to have small annual decreases without impacting net revenue, or they've agreed to a multi-year approach that allowed them to spread the net revenue hit across a few years. The key point is, as our industry shifts to more consumerism, we need to begin changing our mindset away from strategic pricing projects and more towards rational pricing methodologies that take into account the consumer and view the market in different ways. So many of you still have a few smaller percent of charge commercial contracts, or certain areas in your larger contracts that reimburse based on your gross charges. Our mindset for so long was My contract allows me to increase charges, and so I still need to increase the charge-sensitive areas. But as Brad discussed at the beginning of the webinar, we have to start thinking about things differently. We might be incentivized by those contracts to make price adjustments, but does this rationally make sense? Speaking of rational, let's talk a minute about CPTs on your CDM with different prices. Not all organizations have this, but many of you do. So for example, an organization has an X-ray with a CPT code that is listed multiple times in your CDM. Perhaps different departments set up the codes for tracking and the prices have gotten misaligned over the years. They could be intentionally different, and in fact, I expect some HCPCS codes to be different, but far too often we see variances that are unintentional and don't make sense. We've seen many items that are priced anywhere from pennies apart to hundreds of dollars apart, and there's no rational reason behind it. And listen up, for many of these price disparities, there would be no net revenue impact if you assign the same price because they are either very seldomly used or they're reimbursed a fixed rate. So why not clean it up, make prices consistent and rational, and give consumers a better shopping experience? This is an easy one for you guys to check the box on today if you haven't already. So now let's talk about a more difficult task. Making the move to rational pricing requires a hospital or health system to find the balance on competitive pricing and the bottom line. And as you adjust prices, it's important to be able to easily monitor and evaluate the net revenue impact. It's also very helpful to show these numbers to administration or the board to help them weigh in on goals related to price transparency and consumerism. These goals can compromise revenue, and scenario modeling will show that and help them decide where to draw the line for the organization. In this scenario, the difference in draft 3A and draft 3B is isolated to a few MRI codes that are being balanced with increases of surgery and room and board. Being able to see the difference in the net impact helps this hospital decide just how far they can lower those codes without turning their financials upside down.
Great. Thank you, Tara, for that intro and overview. So our next theme of today is how do we integrate these new price transparency mandates that I'm sure are on the top of everybody's mind for January 1. And it really is going to need to be a key factor when adjusting your charges. So before I turn it over to Greg to walk through the mandate, we're going to do another optical illusion poll here. So this one, I'd like to ask what you see first in this picture. Do you see pillars or do you see people? And then we'll talk a little bit about what it means. What did you see first when this image popped up? Did you see pillars or did you see people? And we'll give everybody just a couple seconds here to vote. All right, most of you have voted, so let's take a look at the results. Well, we have a lot of people that saw people first. So if you saw the pillars first, it points to the possibility that you prefer comfort and security over most things. But if you saw people first, that means you're a people person, means you're free spirit, curious, and kind. That's interesting perspective. So Greg, I have a feeling that people have different opinions and perspectives on the topic of price transparency requirements. But could you share the latest on the mandate and what we need to be looking for?
Sure thing, Brad. And obviously, as we talk about price transparency, it's good to know that I'm speaking to a group of free spirits and curious people. So In terms of price transparency, just as a quick level set, as we know, the final rule is now in place. There was a lawsuit hearing from the industry just recently, and it does appear as if CMS is moving forward with the 1/1 date. So in terms of what they are now requiring, CMS did provide additional detail and specific examples with two things that all hospitals are going to have to provide. The first being a new definition of the standard list of charges, and they clarified what needs to now be included. Today we're listing just a charge description and a rate, but going forward after 1/1/2021, this file, your standard list of charges, must now include 5 components. It needs to include the gross charges for items and services reflected in the hospital CDM. It needs to include your discount cash price, which is the cash price for patients that pay at time of service. And this requirement was really added based upon our industry's comments back in the fall during the comment period. CMS is also requiring the de-identified min and max charge, which is really listing the lowest and the highest negotiated rate for each line item and or service. And they're also requiring the payer-specific negotiated charge, which has been one of the more controversial items. Now, the second requirement that CMS included was the list of shoppable services. And the shoppable services, again, are different than your standard list of charges. So there are 2 key items that we have to provide. Now, the standard list of charges and a list of shoppable services. And based upon, again, comments from the industry during the comment period, the final rule was expanded to incorporate shoppable services. And CMS provided 2 different options for hospitals to generate and provide to consumers a list of 300 shoppable items. The first option is a comprehensive machine-readable file, of which CMS did provide a couple of table examples of how that file would be laid out. And it's basically a charge and allowable file for all of your payers and plans. And they provided the option for a consumer-friendly, or what they refer to as a commercial patient estimation tool. Now, CMS acknowledged many hospitals have self-service estimation tools that do allow patients to create an estimate of their cost prior to a service. And in their view, those tools will meet the mandate requirement. And something important for us to remember, that consumers really want to understand their cost, and these tools really provide that in a more efficient way than posting a shoppable file and the consumer having to incorporate their benefit information to really compute what that out-of-pocket component is. So for the 1/1/2021 target date, as I mentioned, you're going to be required to post a list of standard charges that follow the new price transparency final rules. And this means that your current file, again, with only the charge code description and the charge amount, must now include some additional data elements. It's important to note that CMS specifically called out the fact that with the machine readable file, this standard list of charges has to be available without restriction. It needs to be a single file with all the required list of standard charges, being the gross charge, the cash price, the de-identified min and max, and the negotiated charge for all payers. As a single file, CMS also outlined in their Learning Network event that the data can be presented in multiple tabs. So for the CDM charge detail is, you can see here on screen, it should now include an easily understood description of the charge, The corresponding related CPT HCPCS code is required, and the NDC code for pharmacy items are also required. Now, CMS did note that the associated revenue code and or modifiers are optional. They encouraged the industry to incorporate those because it does provide clarity, but those are not necessarily required. Now, for multi-facility organizations, the prices, your charges, should be facility specific. If you have tiered pricing, you would, in other words, have a different charge rate for different service settings. Those service settings, along with the related service location and charge, should be listed. In other words, if you have a different charge rate for inpatient services, such as an X-ray, as compared to the X-ray charge in an outpatient setting, you'll need to list the unique service location charge rate and call those out specifically in your spreadsheet layout, similar to what you see online. The other component that CMS included as a new requirement is the cash price. And with this particular example, the cash price, represented in column G, shows a 55% discount for those patients that pay at time of service. And CMS clarified that the definition of cash price doesn't mean the patient is solely paying cash at time of service, but includes the obligation to pay with a credit card or payment terms arrangement with the patient over time. Now, your percent of charge contracts, for those of you that do have percent of charge contracts, could be your smaller payers, those will be listed as additional columns with the noted discount value. There will be a negotiated charge for all payers with a discount. So if you have 30 payer contracts with an average of 2 plans per contract, you may have a file with 60 plus negotiated charge columns in addition to those other required fields. And finally, CMS noted that de-identified min and max will be the lowest and the highest value across all payers. So this is how you're going to lay out, as an example, that CDM file. The other part that CMS outlined was service packages and your base rates as it relates to those payer contracts where you've negotiated a service and a combined or a service rate, a base rate, if you will. Those will need to be listed in CMS, again, outlined in one of their learning sessions, those being listed in that single file as additional tabs. So as an example, an inpatient DRG or MS-DRG contract or contracts that are based upon CPTs, APCs, EAPG for outpatient services with various negotiated rates, are going to have a separate tab with those listed. So as previously noted, you should be listing your base rates by the contract defined services. Now, CMS noted in the final rules, you do not need to list all the payment rules or reimbursement methodologies, just your base rate schedules. Now, the other part that CMS outlined as sort of the second component of the final rule is this area of shoppable services. And CMS indicated hospitals have a choice of posting a list of 300 shoppable services as a file with the notable allowable for all payers, or you can deploy a self-service patient estimation tool. This would replace a call-in process. It needs to be a self-service tool that allows the consumer to generate an estimate of their cost. Keep in mind, if you elect to post a shoppable file, CMS did provide some very specific examples in the final rule with the file layout. What you see on screen is an example mock-up that we've created that follows those specific rules. Now, CMS noted that they are very flexible, and hospitals will have a lot of flexibility with how the estimated patient cost is presented to the consumer if you go the route of deploying a commercial estimation tool. There are guidelines and there are minimum requirements, such as the 300 shoppable items, of which there is a minimum of 70 CMS-provided items that should be included. and the estimates must be available real time, not as a request it and it will be sent later. Now, in addition, with the self-service estimate tool, CMS did recognize the need to capture certain patient demographic data, such as name, insurance group number, date of birth, etc., to really confirm insurance eligibility, to incorporate that real-time patient benefit data. Now, part of the reason why we wanted to walk through the price transparency final rule, as Tara noted earlier, is that price transparency is really prodding us as an industry to move away from that traditional price shifting or charge shifting and some of the optimizing tactics that we've worked through over the years around strategically pricing services. And it's going to move us towards a more rational pricing methodology, because all of our charges and our base rates are going to now be more public than they ever were before. The information in CMS's mind has been public through what we provide with the EOB to patients. Their logic is we should be providing more information on the front end versus after a service has been provided. As Tara referenced, how we have traditionally used charge data has been to set pricing guardrails. In other words, kind of how do our charges compare in the marketplace? Going forward, you're going to need to begin to think about how you're going to use comparative charge data along with comparative reimbursement or base rate schedule data. So we need to begin thinking outside the box, as Brad has highlighted here, with how we view things. We're going to need to begin thinking about not just how we're going to post these files, but really how are we going to leverage this new data and insight for more rational pricing and a stronger bottom line through really improved negotiations with your payers and improved integrated processes as it relates to rational pricing development. Brad, you may be on mute.
Sorry about that. Thanks, Greg. I think you made some great points there about how price transparency is going to create both challenges and opportunities for us. And then really more importantly, how are these new requirements going to highlight the fact that adjustments to charges and reimbursement are going to be modeled together? So in just a moment, I'm going to turn it over to Tara, and we're going to start getting into some more detailed around things like lesser of charges and pharmacy and supplies to understand how that can potentially impact net revenue. So before I turn it over to Tara, we're going to do one more optical illusion quiz. And the question here is, what do you see first? Do you see the car, or do you see the binoculars? So let's go ahead and poll the audience here. Again, the question, what did you first see when I pulled this image up? Did you see the car, or did you see the binoculars? All right, looks like we're getting mostly everybody's votes in here. All right, let's go ahead and share these. The majority of the people saw the binoculars first. So what does that mean? So if you saw the car first, it means that freedom is very important to you. You take your life at your own pace and you do what comes naturally. Now, for the majority of the people that saw the binoculars first, that means you're more analytical. And then you tend to focus on the big picture as well. So Tara, I think we're going to need our binocular people when we're looking at lesser of charges. Can you tell us a little bit more about that?
Absolutely, and yes, I agree, Brad. Takes a very analytical person when you start diving into the lesser charges. So glad we got lots of them on the phone today. The lesser charges language appears in many prospective contracts. It's a clause that states payers will pay the lesser of the contracted reimbursement rate or the hospital's gross charges. And lesser charges is really straightforward for many of your shoppable services. So for example, if you have a CPT code for a lab panel and you want to reduce the price, you can compile your fee schedule, take the max of them, and then reduce your price, but make sure you stay at or above that threshold. Easy. But shoppables aren't just lab and radiology these days. In the upcoming mandate, on the list of 70 shoppable services, there are 5 MSDRGs and 30 codes total that are considered medicine or surgery. And I think we'll really start to see even more of these in the future. Charges for surgery are typically variable and make lesser of charges more of a challenge. So for those of you who want to decrease a few charges to areas such as surgery that don't have a fixed price, you need to monitor the net revenue impact to these areas. So on the screen, I have a lesser of charges case rate analysis that shows my baseline performance of lesser of charges and outliers that have occurred over the past year. On the right side of the screen, we've taken the new Chargemaster changes, repriced our historical patients, and run them back through the contract to see what impact I have made to lesser of hits and outliers. We're able to get the lesser of hits down from 832 to 701 in this scenario. But if you're decreasing some items on your CDM and see your lesser charges start to go up with a scenario, you'll need to dig in and understand what codes you impacted that likely brought cases below the threshold. And when you start digging, you'll understand if this is related to just one contract or if this is more widespread across your contracts. So for those of you listening that are responsible for adjusting charges, you have a big tedious job. I know how much detail you have in front of you and the hours of time you spend adjusting prices, evaluating, making a few tweaks, and then doing it all over again. But I want to encourage you to take a step back from your task of adjusting prices today and think about how lesser charges is getting in your way of getting to rational, defensible pricing. Benchmarking each payer's lesser charges impact against each other and sharing this with managed care will be key to shaping the future of your pricing strategy. So this data needs to be part of the next negotiation. And if you can share this insight internally, you may be taking an early step in helping the organization maintain your market share and protecting the financial health of your organization. Not to mention, your lesser charges headaches may ease up if managed care helps address them.
Thanks, Tara. And we're going to pause there for another poll. And I'm sorry, everyone. This is going to be a serious poll. No more optical illusions. But we do want to hear from the audience how they are looking at lesser of charges today. So the poll question here: if you consider your charges to be high, are you looking to quantify the lesser of charges and the outlier impacts? And the options here are: no, this is not a concern because we're not looking to lower charges. No, this is not a concern. Our contracts are primarily a % of charge. Or yes, this is a challenge, but we do have systems in place to address it. Or the fourth option: yes, this is a challenge that we are currently trying to solve. So again, the question here that we'd like to hear from the audience: if you consider your charges to be high, are you looking to quantify the lesser of charges and outlier impacts? And we'll give everybody just a few more seconds here to respond. And then we'll go ahead and share the results here with the audience. We'll give 5 more seconds to get your votes in. All right, let's go ahead and take a look at the results here. So this is pretty split across the board. So about as even as it can get. 29% said, yes, this is a challenge that we're trying to solve. 26% said it's not a concern because we're not looking to lower charges. 26% said it is a challenge, but we do have systems in place. And 19% said, no, it's not a concern because our contracts are primarily percent of charge. Thank you, everyone, for giving us your input on that topic. And I'm going to turn it back over to Greg.
Great, thanks, Brad. Great insight. So Tara provided us with a really good example as it relates to the importance of modeling changes to charges back through the payer contracts and changes to reimbursement back through your historical repriced data set. PMMC recommends really updating as you're adjusting charges your modeling data set, or in other words, your historical claim data, with your proposed CDM prices, and then recalculating the repriced data back through your actual payer contracts. That really is the most accurate way of net revenue projections or estimates, and it factors in lesser of charges and outlier scenarios and really all reimbursement provisions at that case or account level based upon your service mix. Here in this particular example, this analytical report shows a hospital that wanted to do a what-if modeling scenario where their overall target gross charge adjustment, and let's say the hospital had a 5% gross target, this particular model played out with a 4.7% gross adjustment, netting out a 0.84% net revenue improvement. So you really want to see and understand that charge sensitivity and where the impact is going to apply and hit the bottom line in terms of net revenue changes as you adjust charges and reprice back through the payer contracts. Now, keep in mind that we need to also ensure that you're not just modeling changes in isolation to how your payer contracts are actually performing. You should be routinely reviewing your payer scorecards to understand not just how accurately they're paying, but also understand how the contract is performing. In other words, are payers earning their discount based upon volume, and really understanding what the effective discount rate is. Again, charges may not be as important to reimbursement, but it's still a baseline benchmark that you can use. So what's the effective discount rate or the contractual adjustment in comparison to each payer, and also in comparison to the initial model projection? In this particular view, you can see that we have by payer the negotiated payment rate along with the effective payment rate, so that we can really understand how well are we performing to our benchmarks, in addition to, are the payers paying what they're supposed to be paying. As we're modeling, we should be thinking about how those contracts are performing and how those charges impact where we are. So going forward, as we move from traditional strategic pricing project methodologies to really this more rational pricing approach that Tara described, there will be a need for more integrated and ongoing modeling of changes to both charges and changes to payer reimbursement. Your modeling should really take into account other components as you're looking at changing reimbursement methodologies, to take into account things like denials. What's the impact of denials as I'm negotiating this contract? And not only by service line, but really down to the reimbursement term and the potential charge line level for items such as high-tech imaging. And similarly, understanding the impact of the patient payment rate should be considered in your modeling. And again, we're trying to push everyone to start thinking about that integrated process of modeling changes to your charges and changes to your reimbursement through that same integrated process. You know, modeling and payer scorecards really allow us to better understand how effective our charge and reimbursement rates really are. In other words, if we are thinking about lowering our charges, as Tara noted earlier, or we may be looking to increase reimbursement, it's going to be more important to really see and understand what services may be denied and how are we really collecting from the patient, or is the patient really being pushed to go to alternate sites, or are our adjustments really not delivering the projections that we thought? It's going to be critical to understand that impact of all components as we go into negotiations on a go-forward basis.
Greg, we've talked a lot about modeling, but I want to touch on two areas that are often neglected from modeling, and that's pharmacy and supplies. Because they're on their own market schedule, a lot of organizations have carved it out from their annual projects. And over the years, we found a number of hospitals that don't keep the cost and markup current. And many items have actually received prices when they originally set up, and then they haven't been updated since. So another reason these areas have been neglected is that the data isn't as readily available for benchmarking. And one of the ways PMMC helps address this is to use the CMS inpatient standard analytical files, and we extract the charges by revenue code category. We can pull pharmacy or supply revenue codes and benchmark against peers. If you appear particularly lower or higher, it points to a difference in charges or utilization that you'll likely want to address. And we can do this type of analysis for all revenue code categories, and you can quickly see if an area stands out. So at a glance, I noticed that the first hospital in this dashboard has an unusually large block of brown, which represents supplies. I also noticed that the middle hospital, whose charges are overall much lower, has a slightly larger block of lavender. So I'd want to drill into that service as well to understand what is driving the inconsistency. You have to slice and dice the data different ways, to uncover some of these hidden issues. So no matter if you're focused on lowering prices to shoppable items, monitoring lesser charges, working on pharmacy or supplies, modeling the changes through your historical patients and contracts is key to helping you find the right balance with net revenue in our new era of consumerism.
Yeah, so Tara mentioned the new era of consumerism. One of the things that we have to recognize is that historically, healthcare services have never been viewed as having price elasticity like other products or services. In other words, price didn't have an impact on the consumer's buying behavior. As we know as consumers, if a store lowers the price of an item, and let's just say like a 2-liter soda that goes from $1.04 a bottle to 98 cents a bottle, that change in many cases may prompt consumers to buy 2 bottles versus 1 bottle. See it all the time in certain industries with price elasticity, where price motivates the consumer to buy more. Now, that same thought process doesn't directly hold true for healthcare services. In other words, I'm not going to request 2 MRIs of my head just because the price is lower, but we have to recognize that as prices become easier to find and easier to compare through price transparency and these new requirements that are going to be out there come 1/1, price may become a factor in consumer behavior that we just haven't experienced in the past. We see it today with payers, to some extent, having third-party organizations often going behind and promoting lower delivery cost options, such as freestanding imaging centers versus the hospital. And in this particular example that you see on screen is the type of analytics that we think will be needed for hospitals to survive in a more competitive environment in the future. Here we're going to need to be looking at combining volume forecasting, prospective contract modeling, and proposed CDM rate changes all together. It's going to be needed as really the market gets more and more competitive around pricing. It's no different than other travel-related industries, not just when we're shopping for product. Again, think about price elasticity in terms of that grocery store example. It's hard to think about healthcare being that progressive, but we have to start to plan ahead and really be ready to keep up with the market shifts and the competition and begin thinking about how we're going to use new data to keep us competitive on a go-forward basis.
Thanks, Greg. And I'm going to run one more poll question here before we move into our final section of the presentation. So we'd like to get an idea from the audience. How do you plan to complete your Chargemaster review for next fiscal year? And the options here are, we plan to do it internally. We plan to get help from a third-party vendor or consultant, or not sure yet. So again, the question here, how do you plan to complete your Chargemaster review for your next fiscal year? Internally, with the help of a third-party consultant or vendor, or we're not sure yet. And we'll give everybody about 10 to 15 seconds to get their responses in. And we'll share the results. All right, let's go ahead and share these. So the majority of you are planning to do this internally, 70%, and another 22% aren't sure yet, and 7% are using a third-party vendor or consultant. So as we wrap up here, now that we've gone through the factors of what we need to consider for our Chargemaster review, let's talk about who all needs to be involved. And this is whether you do it internally or with a vendor or consultant, to really get leadership involved and understand how to put the project plan together. So Tara, can you share what you've seen from clients as far as some best practices?
Absolutely. Well, I think the first thing you need to do is broaden the conversation. Compile a team to address pricing instead of handling it yourself. It just can't be done in silos as it has been for many years in the past. You'll likely want to involve managed care, maybe even marketing, revenue integrity, someone from strategic planning or business development. I touched on this earlier when I encouraged the person in charge of the CDM rate adjustments, which sounds like maybe a large portion of you guys, to push the findings from the lesser charges impact over to managed care. The groups need to come together and analyze where they are today and where they want to end up. So I recommend starting with an analysis of each service line. You start to break it down for each service line. Know if you're competing with other hospitals or regional market freestanding centers, retail clinics. Just know your competition. And then you'll want to determine how you look today from a price standpoint for each area. What percentage of the market share do you have today? Do you expect any significant volume changes? Are you bringing on a couple of new docs in that service line, or is there a competitor opening up nearby? And then another one is profitability. Start to bring in that cost data. Might not be readily available, but start to gather it and see if you can bring that into your decisions. Do you have a service that has really low margins? If so, you need to flag it. And finally, bump those commercial rates against Medicare to get an idea of how they perform and line up. And the goal is to work together towards actionable insights so that you can eventually get to rational pricing. So once you've gathered the data, you'll want to identify areas you're competitive and not at risk of losing market share. You'll be able to identify where you need to focus with regards to competition and what areas managed care should be willing to sacrifice during the negotiations. And of course, you'll need to determine timing. It will likely be a multi-year phased-in approach to get to rational pricing. And once you get started, it will be important to monitor closely and be ready to pivot as the competition lowers prices and negotiations occur. I would also encourage you to work with your payers to achieve rational pricing. Don't expect a win here, but some might say you don't get what you don't ask for. So I know over the past 5 or 6 years, we've had some clients that have made the request to negotiate lesser charges terms out of contracts. And the payers have just come back and said, we're not equipped to do that. Well, it's really unacceptable. And hopefully they'll get enough pressure from hospitals so that will eventually change. And my last recommendation is to establish a formal pricing policy, some type of document that lays out how the organization is pricing items today and how they want to do it in the future. So some charges may be set relative to a Medicare fee schedule. You may be using some commercial data, cost data, or a combination. So for example, a hospital may decide to price labs at 360% of Medicare reimbursement rates and set room charges at 90% of the local market rate with some type of caps not to exceed 105% of the statewide average. And then maybe you mark up radiology 3 times cost. I'm just throwing out some examples. But being able to document this not only gives you a defensible methodology, it'll help you set prices in a uniform fashion as new codes are introduced. And once the policy is determined, changes can go in for the first few years that move toward the goals with caps applied, so no extreme changes are absorbed. So perhaps no item can decrease more than 5% except for XYZ departments, where we put in different caps at 10% or some type of rule. And then eventually each year you apply the rules and you're moving towards your desired goal. So with regards to timing, we recommend you plan 4 to 5 months in advance. I know that's a tough one. But with the challenge of rational pricing and the additional team members that may need to be involved, I urge you to get an early start. I've been involved with a lot of projects like this, and we can get it done quickly, but where the time gets crunched, a lot of times you have to go with the second or third modeling scenario. You just run out of time and don't have sufficient time to explore more what ifs. So really, you are doing yourself a disservice if you don't start early. So for many of you, it's time to get started on your Chargemaster project this year for a lot of your hospitals that have a 12/31 fiscal year in. And here are a few questions to think through to help you make the most of your review. Are you able to analyze and adjust pharmacy and supply prices? How do you accurately measure charge sensitivity? Are you able to analyze and adjust your rate schedule for professional services? Do you have a logical, defensible policy? Are you able to quantify lesser charges and outlier impacts? How is your Chargemaster vendor modeling your data? Are they coming back and asking clarifying questions so that they can accurately model the contracts? And also, does your Chargemaster vendor share that lesser charges impact at the case level that we discussed earlier? And that's all I have for today.
Great. Thank you, Tara. Thank you, Greg. I think Greg needs to jump off for his next call, but Tara and I will stick around for a few minutes. If anybody has any questions, we would be more than happy to answer those for you. If you thought of anything during the session, go ahead and enter those in your questions tab, and we would be happy to answer those for you. I did have a couple logistical and technical questions that I'll address right now. This session is being recorded, so it will be distributed either later today or first thing tomorrow, along with a copy of the slides. So you should be expecting to receive those. And I understand that the audio might have cut out for a few seconds earlier in the session, so hopefully that was caught in the recording. So we'll make sure to send the recording out as well.
Brad, are you still with us?
I am.
Okay. I know we were going to maybe mention the virtual networking. Do you want to touch on that? Do you want me to?
Yeah. And actually, Tara, we just did get a question in regarding the machine readable format files. If I can go ahead and ask that. So the
Sure.
question was, I saw your tables looked like they were in Excel format. Is this considered machine readable?
Yes. Yes, it is.
Okay, great. And if we don't have any other questions, Tara referenced a virtual networking opportunity that I wanted to offer to the attendees on today's call. So we are piloting a Chargemaster revenue cycle networking forum. And the concept is that we would match you up with 3 to 4 attendees from today's call in either a 30 or 60-minute session. And it's really a networking opportunity for you. So we will host and moderate the session, and we'll have some topics out there to discuss, topics like we've talked about today, really just to encourage that idea sharing and learning, because I know that we're all trying to kind of adjust to these new price transparency mandates. We're looking at charges differently. More information is being put out to the public. And so I'm sure there's a lot of people that have questions and are curious how other people are doing it. So that's really the reason behind this. And also with really the inability to meet in person this year with conferences. I don't think anybody's really been to a conference this year unless it was maybe in January or February. We feel like we've lost a little bit of that personal connection. So that hopefully will provide you all with a forum to network and learn from each other. So I'm going to put this out as a poll just to kind of gauge the interest here. So would you be interested in attending one of these 30-minute networking sessions? And again, PMMC will be on the call to answer questions, and we'll be there for that type of thing, but we will not be presenting any material or anything like that. It's really just to give you all a forum. So here are some of the session slots. So if you are interested in attending any of these, go ahead and book the date and time you would like. If you are not sure of your schedule, feel free to email us after the session, and then we can coordinate a time for you as well. Tara, did you have any thoughts to add to the networking forum?
No, I hope it will be a good opportunity for people. I have heard with some of the HFMA groups that some of the networking, of the virtual networking, is starting to pick up, and people are really enjoying it. So that's kind of what led us to this. So we're happy to provide it if there's interest.
Awesome, thank you. And Tara, if you do have a minute, I just did have one more question come in. If we can take that before we sign off.
Okay, sure.
So the question is, what is the expected time frame to be able to engage and implement Chargemaster review and information gathering for the price transparency requirements?
I'm not sure I understand the question. The time frame to prepare for price transparency is start now. It depends on what you need to do for price transparency. If you are gathering these files yourself, you need to get started immediately because I think it is a lot more than you probably anticipate. And as we've worked with some clients, even just identifying those other shoppables, what you want to consider shoppables. When you put a group of people in the room to try and determine what you want to put out there, that can actually be harder than anticipated as well. So giving yourself plenty of time to do that is really important, especially before the holidays. If I did not answer the question, you can feel free to clarify.
Yeah, and if the individual would like to clarify, and if not, we can follow, Tara, we can follow up after as well and get that, and make sure we get that fully answered for that individual. Well, I have seen some interest in the networking sessions. That's awesome news. This is really just a pilot for us, so that's really encouraging to see the interest. We will follow up with those individuals after the call to get that date and time coordinated with you all. And with that, I think that wraps up today's session. Tara, did you have any closing thoughts?
I don't. I hope to see you guys in the networking forum. Look forward to hearing from you guys and letting you guys share your ideas as well.
Great. Well, I want to thank everyone for attending today's call. And Tara, thank you for your time and your expertise. And I know Greg had to leave early, but we thank Greg as well for all his expertise. So I hope everyone has a great rest of the day and great rest of the week. And we hope to be in touch with some of you soon through the networking opportunities. Thanks again.
Thanks, Brad.